We are the Sisters with the Blisters.
My name is Abby.
This is Branda.
And this is Melissa, and we'll be presenting on cholecystitis.
Our patient is Mr. Billy Rubin. He is a 40-year-old Caucasian male with histories of hypertension, high cholesterol, and obesity. He has no known allergies, and his current symptoms are right upper quadrant pain, nausea, vomiting, dyspepsia, and fever. He is a full code status. The reason for admission: the patient was admitted to San Joaquin General Hospital emergency room for abdominal pain, nausea, vomiting, dyspepsia, and on and off fever for the past 2 weeks. The vital signs are the following. Patient's blood pressure is at 148/92. Heart rate is 100 beats per minute. Respiration is at 16. And the temperature is 101 degrees Fahrenheit. O2 saturation is at 99%. And the pain level is at 8 out of 10. When asked the patient what provokes or causes the pain, the patient states, "The pain is persistent, but does worsen after eating fatty or greasy meals." Describes the pain as sharp and has tenderness. The pain begins in the right upper quadrant with radiation to the back and pain in the right shoulder. Pain level is at 8 out of 10, and the symptoms begin 2 weeks ago but are getting worse. Cholecystitis is the inflammation of the gallbladder. But before we talk about cholecystitis, let's first talk about the gallbladder and its functions. The gallbladder is an organ that stores bile. And bile is a mixture of cholesterol, bile salts, and bilirubin. Bile is important because it helps in digestion of lipids. So it helps us digest foods that have fats. But bile is not produced by the gallbladder. It's actually produced by the liver, but it's stored in the gallbladder. So after that liver produces the bile, it's stored in the gallbladder. Then when we eat something that has fats, the gallbladder pumps that bile into the common bile duct, which runs down to join the pancreatic duct. The bile and the pancreatic enzymes will be released into the duodenum to help aid in digestion. So now that we talked about the gallbladder and its functions, let's go back and talk about cholecystitis and the causes. Cholecystitis, or inflammation of the gallbladder, is typically caused by the obstruction of the cystic duct. That obstruction is commonly caused by gallstones. What are gallstones? Well, gallstones are hardened deposits of digestive fluids that can form in the gallbladder. Gallstones are typically asymptomatic, which means they don't cause any symptoms or have complications. But if you're unlucky, then those gallstones can have complications. Gallstones can form in 3 different ways. The first one is cholesterol supersaturation. Normally, the bile can dissolve the amount of cholesterol secreted by the liver. But if the liver produces more cholesterol than the bile can dissolve, that excessive cholesterol may crystallize. Those crystals may grow and form stones. Another way gallstones can form is by excessive bilirubin. So bilirubin is derived from the breakdown of red blood cells. It is secreted into bile by the liver. Certain conditions can lead the liver to produce too much bilirubin, and that excessive bilirubin may cause gallstones. Finally, if the gallbladder is not working properly, the gallbladder will not empty effectively, the bile will become concentrated and can form stones. There are certain factors that can develop gallstones. For example, obesity, gender. They're mostly common in women. Another factor is pregnancy, genetics, nutrition, rapid weight loss, and certain medications. Like we previously mentioned, in acute cholecystitis, a common cause is a gallstone getting stuck in the cystic duct. The obstruction can lead to the backing up of bile back into the gallbladder. Those gallstones can also cause physical trauma to the gallbladder wall, leading to irritation of the gallbladder wall. This will lead to an increased gallbladder pressure and a decrease in blood flow to the gallbladder. That inflammation can lead to ischemia, gallbladder necrosis, inflammation, and loss of integrity of the gallbladder. Over time, continued inflammation of the gallbladder can cause complications such as gallbladder gangrene or gallbladder perforation. So now let's talk about the symptoms. So the patient will commonly have a diffused abdominal pain, which can localize to the right upper quadrant. It could sometimes radiate to the back and to the right shoulder. Our patient can experience fever, nausea, vomiting, and the pain is persistent, but does worsen after eating a fatty meal. And because of the vomiting, our patient can experience dehydration. Diagnosis and labs. So an exam that we do to diagnose cholecystitis is the Murphy sign. The Murphy sign is done by placing the patient supine on a bed. We place our hands firmly on the right upper quadrant. We later ask the patient to breathe in. Inspiration causes the lung to expand and pushes on the inflamed gallbladder below the rib cage. This will cause the patient pain and cause the patient to stop breathing. So what labs do we do for our patient? First, we do a CBC to monitor for white blood cells, looking for signs of infections. We also do a LFT panel. We monitor for the bilirubin. We perform a lipase and amylase just to rule out complications with the pancreas. We're going to look at the electrolytes because since the patient may experience vomiting, we want to check if they're dehydrated. We're looking at the urine analysis to see if bile has been secreted from the kidneys, which will give a urine a dark color. So an ultrasound remains the first line and the best way to diagnose gallstones. Gallstones on the ultrasound appear as a hypoechoic structure and produce a shadow. If for some reason the ultrasound cannot pick up the stones, we do something called a HIDA scan. The HIDA scan uses a radioactive tracer that's injected into the peripheral vein, which circulates the liver. It enters the biliary tree, and if the biliary tree does not light up fully, there could be a possible obstruction. We can sometimes do a CT scan. The CT scan does not increase the sensitivity for diagnosis of gallstones, but is used to detect other complications such as inflammation in the pancreas or the causes of the abdominal pain. We can also do an MRCP, which is a procedure used to determine if there's any gallstone lodged in any of the ducts surrounding the gallbladder. This is done without contrast.
I'll be talking about our nursing diagnosis for our patient who is 40-year-old Caucasian male with cholecystitis. For our nursing diagnosis, we have 5, but our main 3 ones would be acute pain, fluid volume deficit, and risk for impaired mobility. Our first nursing diagnosis would be acute pain related to cholecystitis, as evidenced by facial expression and discomfort when moving. So for our subjective would be pain in the upper right abdomen, and our objective would be facial expression of grimace and showing discomfort and with a pain level of 8 out of 10. Our plan would be for our patient to report that the pain is controlled or tolerated from 8 out of 10 to 3 out of 10 by 1600 of 10, 18, 20. For our interventions, we would teach the patient to meditate, meditation exercises such as deep breathing every time he would feel the pain, or at least every 2 hours. And we also want to make sure that we make time to listen and maintain frequent contact with the patient, because this will be helpful in elevating the anxiety and refocusing attention, which can relieve pain. And also to assess the pain using PQRST. The nurse will ask the doctor for a higher dose of pain medication, and then the nurse will also give the pain medication as scheduled or before activities. For the evaluation, the patient met the goal by stating that the pain is tolerated from 8 out of 10 to 3 out of 10 on 10, 18, 20, 20. Our next nursing diagnosis would be fluid volume deficit related to hydration, as evidenced by nausea and vomiting, and increased metabolic rate due to the fever and adequate fluid intake. So our subjective would be patient stating that his mouth is dry and stating also that he doesn't drink enough water, also the nausea and vomiting. Our subjectives would be this decrease in intake of fluid, increased metabolic rate due to fever, and adequate fluid intake. Our plan would be for our patient will demonstrate lifestyle changes to avoid progression of dehydration, and by verbalizing the of understanding of causative factors by correct fluid deficit by 1600 of 10, 18, 20, 20. Our intervention would be to monitor fluid input and output, and teach the patient the importance of oral hygiene and importance of maintaining proper nutrition and hydration. Also to educate patient about possible cause and effect of decreased fluid intake. And the nurse will also ask the doctor for a lab order such as CBC to evaluate fluids and electrolyte status. And nurse will administer fluids and electrolytes via IV. For our evaluation, the patient met the goal as evidenced by understanding the importance of oral hygiene, which oral hygiene will prevent dry mouth. It also promotes drinking fluids, and by consuming all the meals and drinking a lot of fluids. Our next nursing diagnosis would be impaired mobility related to pain, as evidenced by discomfort, nausea, and vomiting, showing face grimaces, facial expression when moving, and also showing difficulty of getting out of bed. Our subjective would be pain in the abdomen and on the shoulder, and nausea and vomiting. Objective would be discomfort when moving and unable to get up due to pain, and the face grimace, that's facial expression. Also, our plan would be for a patient to get out of the bed and ambulate in the hallway, and will do his own self-care by 1600 of 10, 18, 20. For our intervention, we would check for the patient's ability of level of mobility, and for our patient to encourage them to perform their own personal hygiene, and to teach the patient the importance of walking after procedure. And we would collaborate with them or any occupational therapist to assist the limitation and restrictions. The nurse would give pain medication before activities and exercises. And for our evaluation, Patient met the goal as evidenced by showing her ability to get out of bed, doing her own personal hygiene, and ambulating to the bathroom and to the hallway.
Treatment of cholecystitis includes surgical and non-surgical treatments. Before surgical procedures are done, evaluations are done, which include blood work, urinalysis, and in an abdominal ultrasound. The day of the operation, the patient will not eat or drink anything 4 hours prior to the surgery, with the exception of a small sip of water with any medication. Surgical treatments include a laparoscopic cholecystectomy, which consists of a few tiny incisions into the abdominal area. The gallbladder is then removed with instruments placed into these small incisions. If no complications occur, the patient will most likely be able to go home the same day. Another procedure that is done is an open cholecystectomy, which is a removal of the entire gallbladder. This is done through an incision on the right side under the rib cage. Then, once the gallbladder is removed, the bile duct directly flows into the liver, then into the small intestines. What some people aren't aware of is that you don't need your gallbladder to live a normal life. And after this procedure, patients are able to go home 1 to 2 days after. Another procedure that is done is the endoscopic retrograde cholangiopancreatography, which is known as the ERCP. The patient is sedated during this procedure and is performed by inserting a long, flexible tube with a light at the tip through your mouth into your esophagus and stomach, and is pointed to the duodenum where the bile duct enters, which is known as a papilla. A plastic catheter is threaded through the scope to come out the tip and then move around to enter the papilla and the ducts. Once the stones are detected and the papilla can be widened or cut open, and the stones are then removed. After surgery, it's important to contact your healthcare provider if patient is experiencing severe pain, high fever of over 100 degrees, or order or increase drainage of surgical incisions. Non-surgical procedures include fasting, which the patient is put on an NPO diet to relieve any stress off the inflamed gallbladder. Pain medication is given for pain control, and IV fluids are given to prevent dehydration. At-home remedies can include exercising, which can reduce overall cholesterol levels to help prevent gallstones from forming. Dietary changes should be done for poor eating habits, because consuming foods and high sugars and fats can contribute to gallbladder disease and gallstones. A diet with less fat and more fiber can prevent gallstones and improve your overall health. Another home remedy that can be done is peppermint tea, which shows signs of soothing compound that promotes pain relief, and it can be used to ease stomach pain, improve digestion, and relieve nausea. To ease gallbladder pain and improve gallbladder health, you can try drinking peppermint tea. Some think that drinking this tea regularly can reduce the amount of gallbladder pain attacks that one experiences. Their at-home remedy is raw apple cider vinegar, which contains anti-inflammatory properties that can be useful in relieving gallbladder pain. To relieve the gallbladder pain, one can dissolve about 2 teaspoons of apple cider vinegar with warm water and sip it until the pain subsides. It's important not to drink it raw, as the acid can damage your teeth. Medications for cholecystitis for pain would be morphine, so a patient can receive 2 milligrams IV push, which will decrease the severity of pain. Acetaminophen hydrocodone can be given at 3 milligrams every 4 hours PO to also decrease severe of moderate pain. Fluids like lactated ringers will be given continuously if patient is on NPO diet to replace any fluids lost. The flow rate will be at 125 milliliters per hour. Oframev can also be given at 1,000 milligrams for mild to moderate pain and to reduce fever. Zofran will be given for nausea, vomiting at 2 milligrams IV push shortly after surgery to prevent and treat any nausea and vomiting post-op. Antibiotic like metronidazole will be given at 7.5 milligrams IV push every 6 hours for intra-abdominal infection and bactericidal action.